are advanced in AI and everything, stillbirth is still an enigma. So despite massive advancements in modern maternal care, stillbirths remain a profound medical enigma, with an estimated 30 to 76% of global cases remaining entirely unexplained even after extensive testing and postmortem evaluation. So stillbirth is still an enormous yet overlooked tragedy. So every year we are seeing up to 2 million babies with stillbirth. So I have taken these slides from FOXY ICOG guidelines, and we have a society called Stillbirth Society of India. And this year WHO has come with updated facts on stillbirth. So there are many definitions, like some telling less than 20 weeks, more than 20 weeks, or more than 28 weeks. This year WHO has given like there is nothing like 20 weeks or 28 weeks. It has clearly mentioned like any baby at 28 weeks or more than 28 weeks or crown heel length more than 35 centimeters or 1000 grams, we are considering it as a stillbirth. Fresh is like within the 12 hours and macerated is more than 12 hours. So in India, Ministry of Health and Family Welfare, 20 to 27 weeks has taken as early stillbirth, and late stillbirth is from 28 weeks. So a baby is stillborn every 16 seconds. So we have to concentrate in the coming generations to minimize this stillborn rate. So what is the prevalence? Coming to worldwide prevalence, like it is previously in 2000, it is up to 21 deaths in 1000 births. But coming to 2019, it is 13.9 per 1000 births. And India has drastically decreased from 1.9 million stillbirths in India. It is like 0.34 million. And there is 53% reduction from 2000 to 2026. But the target which has been given by World Health Assembly in 2014 is like 12 or less than 12 coming to 2030. Many of the developed countries has gone to this rate, but India still has to reach it. So even though these many advances are there, but there is a drastic decrease in stillbirth rate in the last century. Initially, because of the improper obstetric care, lack of proper maternal nutrition, almost 50 per 1000 births are like stillbirths in the beginning of the century. Now we have reached this up to only 13 per or up to 10 per 1000 births. So the main cause is like some are not clearly documented, and half of the affected women are not having the proper antenatal care. So we have advanced in assessing fetal heart rate. Gradually, now we are going with a fetal Doppler and then with a CTG machine. But even then, we are seeing the stillbirths. So why there is still a medical mystery in the stillbirth? Because of the diagnostic limitations and low autopsy rates and lack of universal classification. Because some follow some guidelines and Hathron effect. This is like everyone are cautious and they don't want to clearly mention regarding the cause of the stillbirth. But in the next pregnancy, they'll be very cautious so that some reasons may be misled. So, by coming to the risk of stillbirth and subsequent pregnancy, coming to the maternal factors, fetal factors, and socio-demographic factors. Maternal factors, as we all know, gradually diabetes, hypertension has been increasing. And nowadays, we are seeing the cases of HIV again, preeclampsia, severe preeclampsia, and previous stillbirth. Next, the fetal factors are definitely multiple pregnancy, low birth weight, SGA babies, and post-term pregnancy. And in socio-demographic factors, maternal age, high BMI, smoking, antenatal care, and low socioeconomic status, and illicit drug usage. So, what are the factors which may recur in the subsequent pregnancies? Like congenital anomalies is the most common, and again it depends on the type of anomaly in the next pregnancy. Abruption is one more cause where we can see up to 15% of cases stillborn in the next pregnancy. Along with that, vasa previous not determined and trisomy 21 with mutations. And autosomal recessive disorders, we can see up to 25% increase in stillbirth rate. IUGR, as we all know, recurrence is very high. So coming to what are the incidents in the next pregnancy, definitely first stillbirth, next the risk is high. Maternal age, when the maternal age is less than 20 years or more than 40 years, the risk of stillbirth is high. Smoking has obvious risk, increases the risk of stillbirth, and poor socioeconomic status, pre-existing diabetes, and placental abruption. And many of the cases are unexplained. As we all know, 70% of cases are unexplained. Here I would like to mention a slide on the recent guideline of APSOG. It has clearly mentioned, like previously the kick counting which we used to well was, now there is no evidence, and we have to go with the maternal perception of baby's normal movement and start the 26 weeks CTG and ultrasound from 28 weeks, and recurrent reduced fetal movements we should not neglect at all, because maternal concern is the most important thing. So reduced fetal movement is often the last warning sign it has mentioned before fetal compromise. So always give importance to the maternal concern, what RCOG has mentioned in the recent guideline. So it has asked the patient to immediately report preliminary clinical workup and also document with CTG, ultrasound, but don't hesitate to deliver if the patient is bad, and also don't deliver quickly. We can wait even up to 39 weeks even if the patient is good. And one more thing very important in stillbirth is like breaking bad news. It can be difficult, but we have to do with sensitivity, compassion, and empathy with the patient and the family together in an honest, transparent manner. We should explain them why we are doing all these investigations, all these deaths, and everything. Documentation is very important. So what are the coming to investigations? Core investigations like maternal investigations, all routinely, along with Apla panel, fetal gross defects we have to mention, placental chromosomal analysis and DNA storage, and of all fetal autopsy, at least some basic points we have to know, like external examination of baby, photographs of baby and X-ray, detailed macroscopic examination of placenta and cord, which we have to document, and placenta, membranes and cord should be sent in a fresh, unfixed form of macroscopic and histological examination. While collecting the sample, we all know like we'll be collecting skin samples 1 centimeter length, deep from upper fleshy part of thigh, placental biopsy more near to the cord insertion. But the important thing is like we have to collect in a sterile container with a normal saline. Don't go with formal and fixed tissue. So along with the specimen, we have to give a consent form, placenta, maternal history, death certificate, and antenatal ultrasound reports, and the prenatal karyotyping, if present, should be submitted. So here comes the cytogenetics, where the chromosomal microarray is more important than the other thing. So conventional karyotyping rather than chromosomal microarray is better, because even with the macerated baby, we can do chromosomal microarray. And here targeted genetic testing is of importance with placental DNA monogenic disorders. So congenital infections, no longer we recommend to screen for infections, but thrombophilia screen is highly recommended, and parental blood for karyotyping can be tested. So timing of delivery, immediate delivery, we can go when the mother has a risk, but expectant management up to 48 hours we can proceed, and even after 3 weeks with regular monitoring of maternal coagulopathy markers, we can wait. So mode of delivery, always the preferred route is vaginal birth. Induction of labor is preferred. Cesarean, when patient requests, we have to explain and counsel the patient regarding the complications in future, because in the next pregnancy also she has to go with the cesarean section. Unscarred uterus, we all know like if the gestation is less, age is less, we'll start with 200, from 27 weeks 100 and gradually decreasing to 50. After 12 weeks, take the opinion of the senior colleague. Start with mifepristone, give a gap of 24 to 48 hours, then start with meso. So scarred uterus, never go with prostaglandin gel or misoprostol. Always go with Foley's catheter. If needed, oxytocin in a proper augmentation with trial of labor after cesarean. So antiprobiotic prophylaxis is must. Routinely we have to explain. And in the case of maternal sepsis, Intravenous broad spectrum antibiotic coverage must be there. And pain relief is very crucial because the mother is already in the pain. We have to give utmost importance to the pain relief and support. And in case of if there is no DIC or sepsis, even we can go with epidural anesthesia. So postpartum, counsel her, advise her regarding lactation suppression. Dopamine is good, and along with that, cabergoline is good. We should discuss later on at 6 weeks visit contraception, and also recommend regimen for right interpregnancy interval. There is no certain regimen, but at least advise them till 6 months. And there are certain groups, like you already said, like a Stillbirth Society of India and International Stillbirth Society of India. They can connect. And the follow-up is very important. Ask them to come at 6 weeks, counsel them, and ask regarding the proper breast care and also family planning advice. So the most important thing why stillbirth is remaining still as an enigma is lack of audit. So we all should give importance to audit also, because to critically appraise the quality of care received and also consciously look regarding the avoidable causes, clinical, administrative and logistic perspectives, our aim should be improving systems to create better outcomes in the future so that the stillbirth rate gradually decreases by 2030 to less than 10. So ultimate goal is for overall quality of care. So it should be very clear. It should include specialists, neonatologists, radiologists, obstetricians, midwives, and from the administration side. And data collection is important. We should be clear. And there should be no delay in seeking care, delay in reaching care, and delay in receiving optimum care. So coming to take-home messages, just don't neglect, like if mother tells like there is a reduced fetal movement, just seeing the heartbeat and giving an assurance this is not the case today. We have to give importance to the maternal concern. We have to go according with her, act on it. It should be the last warning sign before the fetal compromise. Safe, timely escalation remains a cornerstone for preventing stillbirth and multidisciplinary perinatal audit. And of all, every time you counsel, whenever the patient comes with decreased fetal movements, counsel, document, and if the stillbirth happens, then also documentation is very important. Thank you. Thank you so much for giving me this opportunity. And also on behalf of Vijayawada Society, thank you.